All right, so I'm going to start, and people can just come in as they come in. So this lecture might run over a few minutes. You all can leave at any point, obviously. I'm glad at least 3 people came. I'm happy talking to 3 people if they want to listen. So it might run over a little bit. I'm going to just finish it just so I have it on video. If you all need to be somewhere, obviously, just excuse yourselves. But the end of the lecture is the best, so that's my little teaser in there. So to start off, I feel like I should put a disclaimer in front of all of my talks. So I'm no expert in any of these subjects. I have no training in any of these subjects. I went to medical school like you all, so all of my information is from Wiki. So some of it may be wrong because of that. I mean, I'm a pretty firm believer in Wikipedia. But all I do is I read on Wikipedia, and I try and integrate this stuff. And so, that's my caveat that I'm throwing out there. So with that being said, we'll move on. I obviously told you all that I was going to lie to you. So covering the last lecture, I definitely lied to you. Dr. Hobbs called me on it. I talked about the cerebellum. I said, oh, it's just used for coordination and that stuff. Clearly, that's not true. Nothing is that simple. And that was actually, to be fair, more me just misspeaking. The cerebellum's awesome. It does a lot of things, and it does a lot of stuff in psych. And so, again, we're going to talk a lot about neuroanatomy. It'll be a full lecture on that. We're going to cover a little neuroanatomy today, but just to tell you about the cerebellum, it does a lot more than just motor. So I don't know a lot about the cerebellum, but what I do know about it is first of all, it's called like the little brain. That's its name in Latin. So it sort of functions like a computer. It's built differently than the rest of our brain in the sense that it really has a feed-forward mechanism, meaning that it comes in one end, and it gets ran through it, and it comes out the other end. Most stuff in the brain is completely interconnected, but the cerebellum's not. And so people have a lot of conjectures of what it does. It really comes in to a few cells, spreads out to millions of cells, and then recollapses back to a few cells. And the thought is that it's sort of like a computer. You sort of query it with a question, and it gives you an output of an answer. And so our brain has lots of different ways to sort of ask questions and get answers. And what the cerebellum does is what's called supervised learning. So it's involved in lots of learning. Coordination is just one of them. You wipe out the cerebellum, you lose the ability to do operant conditioning, you lose the ability to do certain affective type things. And so the way that I think about it, and I don't know if this is completely true, is like, let's say I want to reach over and say touch that black ball there. I see it, and my finger starts going towards it, and I'm getting input the whole time. I'm further away, move faster, slow down, stop. So I'm getting this input through my cerebellum that's calculating these distances and velocities. It's our brain doing math to some extent. And it does that for affects as well. It does that for learning as well. So the idea of how strong are we going to think a thought likely is somewhat mediated through the cerebellum. So it would not surprise me if we found some connection in the cerebellum related to OCD type things, for example, where you either get the thought too much or you don't get it enough. And on the other end of it, you might see impulsivity or ADHD. Again, not to completely explain the disease, but just thinking about a possible putative, what is one piece to this disease that we can understand on a neurobiological level. And then just to quickly review the neuron. I'm, again, going to blow through this. We'll start with the neurotransmitters being released. Again, we know all our stuff about neurotransmitters. Welcome. They're going to bind to receptors. Again, understanding that receptors are called what they are based on the endogenous ligand that binds to them. And they can do many different things. Again, we've got the ionotropic receptors that open up an ion channel because, again, physical things are happening, conformational changes. The metabotropic receptors that have to do a whole bunch of stuff for stuff to happen. That might be ion channels opening. That might be changing, activating proteins within the neuron. That might be changing transcription to create new proteins. So ultimately, you'll either get positive or negative ions coming in. If you get enough excitation, the neuron fires its action potential, the voltage-gated ion channels open up, propagates down the axon terminal, and then calcium floods in, and again, we get a conformational change, and the synaptic vesicles are dumping their contents into the synaptic cleft, and we get that whole thing repeated. So that's just a very, very quickie of the neuron before we move on. Again, lots of repetition. So hopefully some of these ideas start to stick. So today we're going to be talking about endocrinology and autonomics. We're going to start off with just basic science, so just the simple medical school stuff that they teach you, and then we're going to talk about what does this stuff really mean? How does this apply to us? What happens when it's working well? What happens maybe when it's not working so well? And what does this all mean for us in psychiatry? So does anybody know what an endo is? It's the opposite of a wheelie. So what we're seeing here is a lot of cerebellum going on as far as balance, and maybe
Is that you?
no, I wish that would be no. I wish I could not endo that hard. Maybe some poor executive functioning, but some terrific cerebellar functioning. All right. So to talk about endocrinology just a little bit, it's focusing on hormones. All right, and we talked about communications. There was paracrine, there was cell-to-cell, there was neurotransmitter. Again, neurotransmitter being sort of small local contacts over distances, one-to-one communications. Hormones are going to get in the blood, and they're going to go everywhere. And that's what endocrinology is all about. These molecules getting in the blood, going everywhere, anything that has a receptor, it's going to bind to it. And the idea behind that is now we can talk about coordinated actions, right? So cortisol goes in the blood, it goes knocking on every single cell. Any cell that has a cortisol receptor, there can be different cortisol receptors, can then use that cortisol to do something. And one cell might do something different than another cell for whatever reason, because of its epigenetic changes, because of whatever's in it, because of whatever is going on in that cell. And the idea is now we can have coordinated types of expression. Single-celled organisms didn't need to worry about this, but as we evolved, beyond that, we had to evolve these mechanisms of being able to communicate to do things functionally, because that's what evolution ultimately pushes towards. It pushes towards functionality. So there's different kinds of hormones. We can broadly clump them into two categories, peptide and steroid hormones. Just looking at the examples, peptide hormones are your stuff like insulin, the endorphins, T4. Steroid hormones are the stuff that come from cholesterol, so cortisol, estrogen, testosterone, those. So to tell you a little bit about them, peptide hormones, going to use a few chemistry terms. Peptide hormones are hydrophilic. Okay, hydro is water, philic is love. So they can dissolve in water, and that's going to tell us some things about their properties. So they don't need a chaperone in the blood. They can't get through a phospholipid bilayer membrane like our neurons have, if you remember. So their receptors are out on the cell membrane, and that makes sense because they can't get in. They also tend to be more fast-acting, meaning that they more change either ions directly, electrical flow, or they change the machinery within the proteins within the cell already. Steroid hormones, on the other hand, are hydrophobic, meaning water-fearing. So they can't dissolve in water, and so therefore in blood they need a chaperone, so they're protein-bound. And when you talk about, this drug is protein-bound, what you're really saying is that you know from that fact that it's likely hydrophobic. So these can obviously diffuse through the phospholipid bilayer membrane, so it has its receptors either in the cytosol or in the nucleus, and that sort of makes sense. It is more likely to bind to DNA and change transcription, so we're already talking about maybe longer-term effects. Again, these are generic things. Obviously, these rules can be broken. Just to throw out a few more words that you might hear, the opposite of hydrophilic is lipophobic, and that sort of makes sense. You can logic through that. Lipo to lipid, fat. So something that can dissolve in water can't dissolve in fat. I'm sorry? Something that's hydrophobic is lipophilic. I'm sorry if I misspoke. That's what I meant. Yeah, I'm sorry. So again, we're going to see multiple layers of control of these hormones. And this is a common theme we're seeing. Our body has lots of ways of regulating these concerted actions. So, we know about the limbic, hypothalamic, pituitary, adrenal axis. There's a level of control for each of those, for thyroid hormone, etc. There's these different layers of control. So again, I thought I'd be clever and, hormones, etc. So I thought that would be a great name for a band. So I did a Google search for it, and it's actually already a band. It's already a band. So my roommate Casey says, you can do nothing awesome that hasn't already been done, and he is usually right because he's a smart guy. But anyways, I haven't heard their music, but they have to be awesome. So go buy their T-shirt or something. All right, so this is what we're all familiar with from medical school. All right, so what happens is a stressor comes in, right? And this is what we say, a stressor comes in, right? So I did cortisol in Dr. Hobbs's lecture, and I wanted to know what was a stressor, right? This doesn't make sense. We talk about stressors all the time. It's a golden box with stressor in it. If you type in neurobiology of a stressor, they all start there. I couldn't find any good articles that talk about what the neurobiology of a stressor is. So I'm going to attempt to make up what the neurobiology of a stressor is. And my guess is that I'm probably somewhat right and somewhat wrong, but it makes sense to me. And so we'll talk about that a little bit later if we have time. So a stressor comes in. Again, we're talking about neurons here. So it has to do something on a neuronal level to activate the hypothalamus, which then, if it releases its action potential, is going to release CRH, which is also a hormone, which can then signal the anterior pituitary to release ACTH, which will go into the bloodstream and largely will work on the adrenals to release cortisol. This is the cascade that we're all familiar with, and then cortisol can come and feed back. So this is a gross oversimplification. It's a lot more complicated than this. The hypothalamus is not a green circle. It's neurons in our brain. And so every single concept that we talked about before, neurons, genetics, receptors, neurotransmitters, all these circuits and modules, we can apply to this here. And we're going to go into a little bit more detail in a way that we can really understand what's going on here besides just these circles. So here we can already begin seeing that it's more complicated than it just is here. So stressor is going to come in. That's largely going to be through the limbic system, and a step before that, through sensory input, whether it be internal or external sensory input. But if the hypothalamus gets signaled, it can go down the adrenal axis to make the cortisol, or it can go down the autonomic nervous system, which we'll talk about later. So from the hypothalamus directly to the medulla, and then it can go into the sympathetic nervous system. And so now we can see how cortisol can be released and how the sympathetic nervous system can be triggered. And it can have concerted efforts on all of these different things here. So this picture looks insane, but it's one of my favorite pictures. I don't think any talk on endocrinology is complete without it. There's one of them in the handout, and I think there's two in this PowerPoint presentation. So first we got to find cortisol, which is right here. All right. So who can tell me where cortisol is made? Anyone?
Adrenal cortex.
The adrenal cortex. Do you know where in the adrenal cortex? Very good. I'm already impressed. So the adrenal cortex has three separate layers, and we'll go through this very, very quickly because it's not super important, but this is exactly what the adrenals look like. And you know, we have this mnemonic because we all love mnemonics, GFR, sort of like the kidneys, and the deeper you go, the sweeter it gets. And so in the glomerulosa, you know, you have the mineralocorticoids, so the salt stuff. In the fascicularis or whatever, you've got the glucocorticoids. And so what we see is this sort of thing here. This, the reticularis, you have the sex hormones, and then in the medulla, you have epinephrine. All right, so it's made in here, in the zona fasciculata. And the reason that I bring this up is, let's think about how cortisol is made. So what do we know has to be the signal that is going to start cortisol being made? Stress, right? But what about the step right before in our little picture before? What's the hormone that's going to trigger it? ACTH. So let's guess what ACTH does. Let's say I cheat and tell you that the rate-limiting step in cortisol synthesis is this here, cholesterol side chain cleavage enzyme. What do you want to guess ACTH does? It activates. How does it activate it? That's right. So ACTH is going to bind to an ACTH receptor, and who knows what it does, whether it activates that enzyme through some conformational change, whether it goes into the DNA and upregulates that. But again, we can already start to think about what's going to happen. So beautiful. We're integrating this stuff. We can start from a few things, start understanding how this stuff works. So why does it make cortisol, and why does it not make, say, DHEA, dihydroepiandrosterone, which we're going to talk about later? Again, I'm asking you to think, which is not something you've been asked to do in a long time.
It acts on certain enzymes, that's why. It actually stimulates certain enzymes, that's why it goes this direction.
That's right, because it depends on the milieu of enzymes within that cell. So we have the same DNA in all of our cells. So why in, say, the zona fasciculata, does it only go to cortisol? Why are some enzymes expressed but not others? This is coming back to a question of cellular differentiation, right? Sure, absolutely.
Yeah, so basically what's going to happen is like certain receptors will send certain proteins to stimulate certain genes to produce certain, it depends where that enzyme acts and what level is it, level like it acts on the level of the DNA or the gene or the protein or whatever. So that's why in the zona fasciculata there will be certain enzymes that are active, in the zona granulosa will be others that are active.
That's right.
That's why.
So it's, what I would say is that these enzymes, even before ACTH come in, are activated. And they're activated because there's a baseline level of transcription because of epigenetic factors, right? So if we want to make, say, DHEA, the area of the body that makes that is going to be epigenetically different, right? The zona fasciculata can't make epinephrine, but it can make this because it doesn't have the ability to make the enzymes necessary to shunt it this way. So looking at that, we can guess what enzymes are going to be, say, in the testes or in the... So you can start to make sense of this. It's a ridiculous-looking picture, but once you sort of see what's going on here, you can look at a cell, know what it makes, and then know... You can make a good guess, and you're going to be right most of the time, were you to take a cell from that, cut up its DNA, and look at its epigenetic coding, you could guess what's going to be methylated out or not. And again, this is us integrating to see how these concepts are actually making something real in our bodies. And before I go on further, we talk a lot about rate-limiting steps, and that's assuming normal, right? So if you have a problem either through some SNP in 11-beta hydroxylase or through some epigenetic change that's happened, your rate-limiting step might not be that anymore if this has been down-regulated. And that's where we start talking about individual differences, right? Why the same treatment might not work for every single person. So that's just one idea before we move on any further than that. We'll talk briefly about cortisol.
Can I add something?
Sure, yeah.
HSD, that's how we say it.
Mm-hmm.
That's also on the business, like you said. And
Of course, it has to be, right? Because we're going over here. So you've got to be able to push it past this way.
I found it like in my publication that it's like actually down, it's decreased in when you expose mice to like smoking. So that actually led me to go forward and measure the testosterone, and it was decreased. So that smoking actually decreases testosterone in the body. So in another way, that man is less man when he's a smoker.
So that's a wonderful take-home point. I do not condone smoking by any means. And we're going to talk a good bit about actually 3-alpha HSD, which is not on this. It's actually shunting this up here, which is more going towards sort of neurosteroid hormones. But again, that's a wonderful point, Riyadh, because what it's letting you do is sort of make sense of this. Instead of just guessing, we can have some sort of logic behind it. I want to give just a couple more ideas on cortisol before we move on. So again, it's activated by 11-beta hydroxylase, or HSD is another way of calling it. This is interesting because it's been seen that this is changed in metabolic syndrome. And it just makes me wonder that, it's involved in cortisol synthesis. We see metabolic syndrome with some of our medicines, particularly the atypical antipsychotics. And there's interesting data that shows actually what we might be seeing is people who gain more weight actually tend to have more of a benefit from these medicines. And so what we might be seeing, again, is this same common pathway being modulated. And again, that's just a guess from me. I'm not sure whether that's true or not. We're going to talk more about DHEA and allopregnanolone later, which isn't on this slide, but we'll get back to it. So again, we're going to apply these same principles to synthesis of epinephrine. This is a pretty important neurotransmitter slash hormone that we don't talk about a lot. So I don't want to steal anybody's thunder when we're going through Dr. Hobbs's lecture. But just very briefly, so ACTH comes in and it upregulates dopamine decarboxylase and dopamine beta hydroxylase, which shunts everything to norepinephrine. And then cortisol comes in and upregulates PNMT to make epinephrine. And again, I want you to see that SAMe is over here, S-adenosylmethionine, as a cofactor, and that's something that comes up a lot, likely has some implications psychiatrically, but we don't have time to go into it here. But pay attention to the cofactors sometimes because you'll see certain things coming up. over and over. And again, why is epinephrine only made in the medulla? Because PNMT is only made in the medulla. It is the only place that has the ability for PNMT to get made. Hello, sir. Oh, perfect. So again, we're starting to understand how these concepts can all be applied to these chemical reactions. So here's the autonomic nervous system. It's a very, very busy picture. I'm trying to move through the basic science stuff so I can apply it more clinically. So the autonomic nervous system is a combination of the sympathetic nervous system, the parasympathetic nervous system, and the enteric nervous system. We're not going to focus a lot on the enteric nervous system. Again, the autonomic nervous system really has to work to control a lot of our physiological functions. And I don't want you to think of sort of the sympathetic and parasympathetics as doing opposites. Sometimes they do, but usually they're just complementary. And we think of relative amounts of tone. So there are times when there's more sympathetic tone, times when there's more parasympathetic tone. And this is very quickly fluctuating somewhat throughout the day. Every time we breathe, we have to have a change in sympathetic and parasympathetic tone as our pressure in our chest changes so we can maintain blood pressure and those sorts of things. But when we see more of a difference between the two is when they become more, clinically significant. And we think of the sympathetic nervous system, again, as the fight or flight system. It's more probably better to think of it as sort of the quick response monitoring system. I read that somewhere, and that makes more sense to me. When it gets activated in general, we increase our blood sugar, we shunt blood to our muscles that we need to run away, we shunt blood to our lungs, we take blood away from our digestion, from our reproductive glands, we focus on what is going on immediately, and we prime our memory. And the idea is that it's a concerted effort that could be useful in a certain situation. And then similarly, the parasympathetic system is a complement to that. It's sort of thought of as the rest and digest system. So it's what happens when you're sort of relaxing, you're healing, you're digesting, you want to sleep, and those sorts of things. And you can see that they each work a little bit differently. They all start up in the medulla, and then they send their signs down. The sympathetic is what we call thoracolumbar, so T1 to L2, and then it goes out to sort of a sympathetic ganglion, and then ultimately out to the target tissues. The final step here is mediated by norepinephrine, generally. And then here, we see some cranial nerves, so 3, 7, 9, and 10. We'll focus on 10 a little bit, which is the vagus nerve. And then S2 through S4 is how it gets out. And this is completely done through acetylcholine. So again, norepinephrine binds to, do we know what receptors norepinephrine binds to? So it binds to our alpha and betas in different amounts in different places. And so when we think of sympathetic nervous system, that's alpha 1, alpha 2, beta 1, beta 2, and beta 3, and all of the subtypes. So anything that works on alpha 1, alpha 2, beta 1, beta 2, beta 3 are acting on our sympathetic nervous system to modulate it in some way. The parasympathetics are done. Do you know what neurotransmitters used in the acetylcholine? Do you know what receptors they bind to? Nicotinic and muscarinic. In the parasympathetic, do we know mainly what we're talking about? Muscarinic. So M1 through M5 receptors, there's a lot of controversy on them, but when we're thinking of acetylcholine and muscarinic effects, that's modulating the parasympathetic system. All right, so let's see it in action here. So this picture? To interwebs. Just the internet, I just did a Google search. You're saying there's no sympathetics going to the heart?
I don't think there is.
Well,
it should be through the circulation if it's also. That's what I thought.
Okay.
I can't
Well, again, I'm not an expert.
Because there's only vagal stimulation. There's no parasympathetic.
Okay. So again, I have no idea. I'm not an expert on this at all. I just stole the picture. So certainly it can indirectly get into our heart through heart rate and stuff. But again, I'm not sure about the specifics of this picture. So this here is Ripjaw Halchin. He died earlier this year, so I've got to give him a little bit of a shout out. He was living large until the thug life took him. So moment of silence for this guy. Pour out an ounce of cricket juice. So what he's here to symbolize is the idea of we're going to talk through this system from start to finish, the fight or flight system. So we see a lion, all right? Sensory inputs come in. They get translated from our retina into sensory input, ultimately into the limbic system, and then it's got to make a calculation. How dangerous is this? And that's where learning comes in and where we'll talk more about how learning can influence things. Likely, we have some hardwiring that's going to help us be afraid of a lion. If we get a strong enough of an input, which again can be modulated by a lot of things, and our body says, all right, this is a stressful situation, what the limbic system does is it says, let's sound the alarm. And so it sends its signal from the limbic system to the hypothalamus, mainly the paraventricular nucleus. And from there, the hypothalamus can send it down the HPA axis, and the hypothalamus can also get into the sympathetic nervous system. So we understand how those pathways work. So if you think about it, you see the lion, blood goes to your muscles, goes to your heart, goes to your lungs, you're zoned in, you're scanning the environment for threats, you're ready to learn, you're mobilized, and you can run. So if you get away from the lion, that's a perfect combination of activities in your body to help you escape the lion. And if you escape the lion, you're primed to learn what you did. And so that's our body adaptively using this system in a functional way to help us escape danger. And you can see how that could be very evolutionarily helpful. So this is when it's working well. So just a quickie on neuroanatomy before we move forward. We're going to talk a lot more about this later. So we'll start with the limbic system. We'll see a whole bunch of stuff here. The cingulate gyrus, one of my favorite sort of parts of the brain. I pick favorites for sure. Here we can see the amygdala, the hippocampus, the hypothalamus, the pituitary here. Do you know why they call it the hippocampus? What that means in Latin? Seahorse. This looks nothing like a seahorse, right? What about this? Amygdala?
There's a way you can fold it, and you can look at it a certain way.
Do you know why they call it the amygdala? It's almond. So I am now dubbing this the sacculus. We're not calling it the pituitary anymore. Sacculus is Latin for little sac. So again, here's our hypothalamus. Again, the signal's going to come in.
Also, or?
We'll leave the mammillary bodies alone on this one. And again, we can see here the anterior pituitary and the posterior pituitary, the hypophyseal portal system here, the hypothalamus dumping its blood, again, into a local region where it can respond in the pituitary, and the posterior pituitary, which is more acting like a direct neuronal to neuronal connection. We get oxytocin and vasopressin here, and we get the flat peg hormones and the anterior pituitary. So FSH, LH, ACTH, TSH, prolactin, endorphins, and growth hormone, and also MSH, and some other stuff too. So again, I'm focusing a lot on cortisol and ACTH, but I want you all to understand that you can apply this same sort of system to all of these different hormones. And when you go over this in second year, think through this system on each of them. All right. So now we want to talk about what happens when cortisol loses control. So it can be helpful, and now I'm going to make the argument that at times when the cortisol system isn't well regulated, we can run into some problems. And this is true with most of the hormone pathways.
Seems like this is not like norepinephrine or dopamine.
We'll stick with cortisol on this one. We had the C for censored, so I stuck with it. So again, usually cortisol can go back and regulate what's going on. And it's actually a lot more complicated than that. And we're not going to go into fully how it gets regulated, but we see lots of these negative feedback pathways. So cortisol can go back, turn off ACTH, turn off CRH. A lot of this is done in the hippocampus, and we'll talk about that a little bit later. But we can think about there's a lot of ways to have excessive cortisol, right? Your negative feedback can be broken. So when cortisol is high, it doesn't have a way to shut it down, and that's Michael Meaney's rats, right? The hippocampus, you get a stress, you epigenetically methylate the cortisol receptor gene, so it's downregulated. You now have decreased cortisol receptor expression on the hippocampus, so it is less able to turn down that response. So again, here's applying the principles of epigenetics to genetics to hormones to function ultimately. So that's one way, a messed up regulation, and there's a lot more than just cortisol that downregulates this. There's a lot of other...
Guys here.
Good observation. So the other way is that you can get into this cortisol pathway quickly. So you can have an itchy trigger finger from the limbic system to the hypothalamus, right? That's the person who's scared of everything. Just, you're overly anxious. Everything triggers stress for you. You view the environment as more stressful. You're going to release more cortisol, even if the rest of your sort of systems are intact. And the third way is, you're just in a stressful environment. It's not that you overview stress, it's just that your situation is truly stressful. So, we're sending troops overseas, we're telling them to shoot at people, they're being told to shoot back. I mean, it's a very stressful situation. It would make sense that you're going to be living with more cortisol. So let's think about how these helpful things that we mentioned earlier, what it would be like were cortisol not to be regulated. So the first thing we talked about was increased blood sugar and insulin resistance. And so I think we can very easily see how you have too much cortisol over time, and you end up with something that looks like diabetes, or the picture of insulin resistance. You get too much of this.
Well, what's the chicken and what's the egg in that situation?
Well, it doesn't matter, and that's sort of what I was getting back at either way. Too much cortisol, if you can't turn the system off, you're going to express, the symptoms of whatever too much cortisol is, however you got into that system. So again, if you've got blood to your muscles and it's not shunting to your genital organs, you can't shut down, you have difficulties with sex, you have difficulties with erection. You trigger your immune response whenever you set off this stress pathway. And this is something that gets confusing. But once you trigger the stress response, in the immediate sense, you actually are upregulating this generic inflammatory response. And what it does, it's not antibody specific. What it's doing is it's just indiscriminately killing anything that sort of looks like it doesn't belong in your body. And that's very useful when you're at risk of being wounded or having pathogens sort of brought in. But this chronic inflammation, this general inflammation over time, likely leads to sort of autoimmune conditions, chronic pain conditions, fibromyalgia type stuff. And I'm going to argue later on the lecture on inflammation that inflammation is largely implicated in our psychiatric disorders, especially depression and anxiety. And I joked, and I didn't joke, I said in third year in research, I wanted to do a study looking at Tylenol for the treatment of depression. And sort of was laughed at, but I honestly think that there is a method through decreasing inflammatory pathways.
It's antidiuretic and not anti-inflammatory?
It is anti-inflammatory. It really is anti-inflammatory. It can turn down inflammatory markers, particularly CNS cytokines, like IL-1, IL-6, and TNF and stuff like that.
People think of it more antibiotic.
That's right. In our brain, it acts largely to decrease CNS cytokines. Okay. So that's what the studies show. So, all right. So let's think about who here knows the B criteria for generalized anxiety disorder. So not the excessive anxiety sort of stuff. The physical symptoms.
Muscle tension.
Muscle tension. All right. So muscle tension. What does the sympathetic nervous system do? Right. Blood to our muscles, muscle tension. Irritability. So irritability. You can imagine if you've got to fight a lion, you've got to be ready. You've got to be aggressive. Right. Difficulties concentrating. If you want to be scanning the environment looking for threats, you don't want to be able to relax and concentrate on a book, right? Difficulty sleeping. It's not helpful to sleep when you're running away from the lion. You want to be focused, you want to be in the zone. Restlessness, fidgetiness, all of these things make sense as manifestations of a sympathetic nervous system that's lost control. You've lost regulatory ability over this cortisol, over this sympathetic nervous system in responsiveness. And so I would argue, not that this is just the sympathetic or parasympathetic nervous system going on or just cortisol. I'm saying this is a part of it. And the idea of saying serotonin in isolation means nothing outside of the context of what pathways is serotonin modulating. So again, I'm encouraging you to think functionally. Serotonin does not equal muscle tension. This does equal muscle tension in the way that we talked about earlier, in the way that it very really can get into these systems which can have real symptoms.
Do you think in the future we're going to have subtypes of generalized anxiety disorder, like cortisol, like...
We are going to talk, that's going to be the last slide, and I think in the future things are going to be very different, and I'm going to talk about what I think might be different. And so I want to ask a couple of other questions. I don't know where the cancer floor is anymore because stuff has moved around a lot, but... So if you get a consult, right, you're a second-year resident or a first-year resident, you get a consult at night, 40-year-old woman, no previous psych history, she's hitting on male nurses, she's not sleeping, she's talking crazy, she's acting very bizarre. What happened? What just happened there? What's your diagnosis and what happened? I'm sorry? That's right. She's getting a cancer treatment and she's getting a steroid. She's getting Dex or she's getting Pred. And so what does that look a lot like? Which of our... Well, I would say more like mania. And so, we're thinking about all these crazy things when we have in front of us a very real mechanism for getting in the system. Again, I'm not saying bipolar disorder is excessive cortisol. I'm saying there is a tie between the behaviors manifested in bipolar disorder and this system, is what I'm saying. And so that's the way that we need to be thinking as far as functionality goes. So, all right, we'll move on. This is just a very quick, we're not going to go over this in detail, but just, I'm not making this stuff up. When I talk about the sympathetic nervous system, epinephrine going and increasing blood sugar, here's the pathway. Epinephrine gets released in the blood, gets to the liver, it does some stuff, second messenger type stuff, right? It activates glycogen phosphorylation, conformational changes, which turns glycogen to glucose 6-phosphate. Again, very real processes. This is not magic. This is stuff interacting with other stuff to ultimately produce a product, right? So we can only take this for granted once you understand these concepts. But until then, we have to sort of, I've got to prove to you that this is real, and I think that you should want people to prove to you this stuff before you start taking these steps for granted. All right. So a little bit more on cortisol, right? We talked about how cortisol was regulated by cortisol feedback, but clearly if you just look at this picture, that's not the whole picture. Clearly there's more to it than just cortisol in the blood. It's very, very complicated. It's based on circadian variation, as you can see. You get a spike at 4 a.m., a spike at 8 a.m., a falling off throughout the day. This isn't a healthy cortisol response. So people knew that cortisol maybe has something to do with depression, right? So there were thought leaders who were saying depression is just hypercortisolism. And now people are saying depression is just hypocortisolism. And again, any explanation that has just in it is incorrect, I assure you. Because that just doesn't make any sense. It doesn't have explanatory power in itself. And so again, lots of stuff is controlling cortisol throughout the day, circadian variation to one extent. But again, circadian variation isn't an explanation until you really understand what that means, right? We have real things that can monitor changes in the day. And there's delta sleep inducing factor that's probably very, very important in this. My guess is it's going to get some prime time in the next few years. And again, this isn't super scientific, but I bring it up here just to sort of show you an example of how we have to look at this as a context, as a system over time. None of these things exist in isolation. So, again, maybe early on in the stress response, you do get this hypercortisolism, and as your system changes and adapts and burns out, you start seeing changes. And again, I don't want you to think of this as this is what happens. This was not pulled from the most scientific source, but I think that these things can change over time, and just thinking of something as a number, that's not going to be what happens. That's the stuff that's easy that we've already figured out. Moving forward, we're going to need to get a little bit more sophisticated to really give a true scientific explanation for these things. All right. So I want to talk a little bit about drugs. We prescribe a lot of drugs. Anyone want to guess what that is? I wouldn't expect anybody to know this. It's Prozac, okay? So what's Prozac? I'm obviously setting you up. I would not ask an easy question if there was no point in it. So nobody's biting. Good for you all. Well, this is what Prozac is, okay? And it's even more complicated than this because this changes a little bit. But let's just say this is Prozac. This is what it is at the beginning of the day. This is what it is at the end of the day. We think of it as an antidepressant. We think of it as an SSRI. But that's just us lumping it in a category. Okay, this molecule does not know that it's an antidepressant. It only knows its chemical properties. So we think it's an SSRI, right? And you can look at these studies, and these are just, dissociation constants and chi. And you can see here, it is fairly specific based on this chart for serotonin reuptake, right? But, it's also about 10 times less specific for noradrenaline or norepinephrine, which actually isn't that specific, which is why we see noradrenergic properties of serotonin at high doses. We also see noradrenergic properties at low doses because these things are a system. We're talking about changing the effects of one neuron. Of course it's going to change other neurons or else it wouldn't do anything, right? When I ask you, are you happy? You don't say, hold on, let me count my receptors, okay, oh yeah, I've got this many. No, it's a functional circuit that is using these things as a means of modulating it. So again, if you look at this, Prozac looks like an SSRI, sort of. But what I'm going to argue is that you've already missed the boat at this point, because serotonin does a lot of things that aren't on here. It can modulate sodium channels. It can modulate T-type calcium channels. It can decrease inflammatory cytokines. And what we're going to talk about next is that it can influence. So, as in science, you have to test things multiple times, and you're right when you get widely varying results. So these are just two different studies with very different results. And that makes sense, right? Because nobody's exactly the same. And if you're sampling different populations, they might be different genetically, right? This is in a system. This is in vivo. And so when you're doing something in vivo, there's a lot of variables. And some things have more variation than others, and my guess is that this is something that shows more variation among the human species. And so, if you get different samplings, you're likely to get different numbers. The last thing we're going to talk about that Prozac can do, that not all antidepressants can do, is modulate something called 3-alpha hydroxysteroid dehydrogenase. And so, all guys in here, so maybe I can actually be the expert on this. Women would blow me out of the water here. So here's a woman's menstrual cycle. Okay, I'm not going to be sexist because this is on video. Not that I'm sexist anyways, but so I want you to focus on. I want you all to focus on this purple line here. Okay, so we think of some women have behavioral changes and emotional changes premenstrually, or throughout their cycle is one way you could think about it. And so we think of it premenstrually. It's probably more perimenstrually. It's also can carry over into here. And what we see is, 4 to 7 days before the cycle is when their symptoms start. And what's also happening is progesterone is falling off. And so now we're going to go to this next slide, okay? So here's progesterone, and it's also over here. So this isn't a complete, chart of steroids hormone synthesis. It can get converted over to allopregnanolone, which is a neurosteroid hormone. So as progesterone falls off, allopregnanolone is going to fall off, right? You're decreasing one side of the equation. Prozac can increase 3-alpha hydroxysteroid reductase. And what that can do in certain people is increase allopregnanolone. So allopregnanolone is a potent GABA-A agonist, all right? So when women have this falling off of progesterone, they're also having a falling off of allopregnanolone. What do you think that may manifest as if we're having a falling off of a GABA-A agonist in the brain? This is a neurosteroid hormone made in the brain, released at neurons in the brain as a GABA agonist. So stimulation, okay. So
that's the PMS.
that's what
How much does this really play a role?
So what you're seeing is akin to a benzodiazepine withdrawal, to an alcohol withdrawal. And
Plays a role.
And so, that's where I'm going with this. I'm not going to just stop and leave the room, Ivan. So what you see is irritability, right? You see cognitive changes. You see things that look sort of akin to some type of benzodiazepine-like withdrawal process. So how long does it take for Prozac to work? Everybody knows the answer to this, right? 4 weeks or else it can't be working. So that is how long it takes for serotonin receptors to be downregulated. But that's not the only way that this can work, because Prozac doesn't know what it's doing. It's just a molecule. So you can upregulate allopregnanolone in about 3 days. And there's great studies in rats and some in humans that show allopregnanolone decreasing change of allopregnanolone is reflective of PMS symptoms, and resolution of allopregnanolone in rats correlates with resolution of symptoms. And so I would argue that we are getting, there is truth in this. I would argue that there is some truth in this to the responsiveness of a woman's premenstrual symptoms in a medicine like Prozac.
Have they shown Prozac more efficient than Effexor?
So there are studies that show 3-alpha hydroxysteroid dehydrogenase activity with the medicines, and the medicines that show activity with it are shown to be better in treating PMS symptoms. So yes, this is something that's proven true enough across the board that I think there's some reality to it, which is amazing in psychiatry. Hallelujah. That's right. That's why it's marketed as Seraphim. And it's actually a once dosing. That's right. So if you think of it, so I'll tell you a little bit of a story. And so I joke a lot about, being a doctor and downplaying it. But, it really is. It's pretty cool to be a doctor. It's sort of an honor to be a doctor. People come to us when they need help, and they tell us a lot of really private stuff. And I think that we owe it to them to be honest with them about our limitations and knowledge of the field. And I've mentioned this before when we just think our patients are faking. I say first, give them the benefit of the doubt. And I'll give you an example of that. So I did an intake on a woman at Northridge last year. About 30 years old, had significant premenstrual worsening of her depression. It sounds like she had depression, but very, very significant worsening premenstrually. I started her on Prozac 20 and saw her back in 2 weeks. She came back amazingly better. I mean, so much better. She was so happy. I file my note. I, turn it in or whatever. I get an email at the end of the day. I'm not going to name any names. We can guess who this is. To speak with this person. So I go and speak with the attending and learn from your attendings. They're wonderful. This is just a single bad example. And she comes in and she's like, we need to rethink this diagnosis. And I'm like, well, what do you mean? She's like, well, my guess is if she responded after 2 weeks, we got to start thinking about personality issues. This is clearly a placebo effect. Is it a personality issue? And, I try and sort of explain this. Of course, it's not going anywhere. But again, we need to give our patients somewhat a benefit of the doubt. Yes, it's a possibility that there are non-specific drug effects that are going on here. There's also a possibility that we don't know everything, which I think is probably more likely most of the time. So again, I want to encourage you to think functionally. Prozac is not an SSRI first. It is a molecule that has different effects in our body first, and often acts as an SSRI as one of its potential mechanisms of action. It can do other things. And just being an SSRI doesn't mean much unless you understand the functionality of these changes in circuits. That's sort of what I'm arguing towards. So now let's have some fun. All right, and we got plenty of time actually, so that's good. I'm going to make a few arguments for why I think this stuff is important and why I want to tell you about it because not a lot of people tell you about it. VNS, right, was used for a treatment in seizures, found to be pretty effective. We found that people's depression symptoms got a lot better, right? No effects on serotonin directly. I guarantee you there are effects on serotonin, but none directly. And so, that's weird. What's going on there? And, what we find is that there is autonomic system dysregulation in a lot of our illnesses. And what we find is there's usually not good amounts of parasympathetic tone. And I'm going to come back to that on the next point here. Lap banding was just my reminder to say that, I talk a lot about, inputs coming from the environment, us seeing things. I also want you to understand what we feel is largely dependent on what our body is telling us. We have tons of receptors. That picture only shows the receptors going out. They come back in. We are constantly getting feedback from our organs, from our heart, etc. That is factoring into how we feel and how we behave. So it's not just this stimulus from the outside, it's largely stimulus from the inside. Crying is a huge parasympathetic sort of response. And so, yes, I think that there is some benefit to the catharsis of talking to somebody about something that you've been wanting that's emotionally charged and getting it off your chest. But I would argue that part of the reason that we may feel much better after we cry is that we are giving ourselves some parasympathetic tone that our body desperately wants. Similarly with deep breathing. What you're doing is you're creating a pressure change in your chest that's stimulating your vagus nerve. And so, we can just take a few deep breaths here. We're not taking any drugs. You will feel differently. So again, similarly with yawning. And so one thing I've noticed doing this for a few years at this point is that psych patients and pain patients and patients that have this gamesh of migraines and pain and anxiety and personality issues have weird pupil sizes. And I haven't seen a study on this. I'm not going to say anything certainly. But they tend to have bigger pupils, and this is just from my observations. It could be completely, biased. And I would say more so than large pupils, they have reactive pupils. I'll notice when I'm talking to them, if I say something emotionally charged, their pupils respond much more than a normal person. And I would love to see a study where we took normal controls, healthy people, so to speak, and psychiatric patients, pain patients, measured their pupil size and measured their pupil change when given a small stimulus to light or darkness. And it would not surprise me if we saw autonomic dysregulation noted by a change in pupil size of greater magnitude in psychiatric or pain patients. And what I didn't mention is that these are autonomic phenomena. So sympathetic, it gets bigger. We take in more light. Parasympathetic, it gets smaller. So that's why I mentioned that. And I would love to do that study. It would be easy. There's not a lot of consenting. I bet you'd find something if you got a big enough sample. All right, we're going to talk about sex a little bit. And it's guys in here. So it'll be... Some of you may already be thinking about sex, but let's think about what might be happening with our sympathetic and parasympathetic systems when we have sex, and maybe why we feel the way that we feel when we have sex or after sex. So, again, fortunately, I do not have to comment about women and sexuality, because I would obviously be lying to you, because I don't know very much about that. Right, Mom? So, here we go. I'm going to draw a little chart here of sympathetic and parasympathetic tone. All right, and so red will be sympathetic, and let's say green will be parasympathetic. Okay, so we come home from work, we eat a meal. You know, our parasympathetics and sympathetics are sort of hanging around during the day. We're ready to relax. We eat a meal. Our parasympathetics sort of come up. All right. We're hanging out, significant other or alone or whatever. Our parasympathetics go up. We're relaxed. We have the ability to become sexually aroused. So sexual arousal is largely mediated by parasympathetics. We engage in a sexual encounter, whether that be, you can use your imagination, whatever gets you off, significant other by yourself. And so we have this sort of thing going up, balancing it. As we begin our sexual encounter, our sympathetic tone begins to increase. And you can think about this, how your thoughts and your behaviors increase as the sexual encounter goes on. And when the sympathetic tone climaxes, so to speak, it has a very quick falling off. And so this is the point of orgasm. So think about how you feel during a sexual encounter. And think about it in terms of this sympathetic or parasympathetic response, right? You feel it building up in intensity. You can tell that you're becoming sort of more muscularly active, more sort of sympathetically going, and then when you have that falling off, what does it feel like? This is this parasympathetic tone that very quickly is overwhelming the fall off of sympathetic tone. And you just want to sleep, right? You just want to relax. It's, that gives you a sense of the difference between the two that I think people can understand to some extent. All right, so now a demonstration. I need 2 volunteers. Well, maybe just 1 volunteer, actually. Any volunteers? Yes! Oh, gosh. I don't even know this guy. I'm going to be really bad.
What's that?
Okay. So what I'm going to have you do ultimately is dunk your head in this ice bucket. But before we do that, we're going to do a couple of things. I'm super serious. You don't have to volunteer for this. Do we have anybody who's...
No, that's all right. Okay.
If you want to...
the water too? Fill the water?
I'm going to...
I think we just volunteered
Alan?
That's good.
I'm Alan. No, my nickname... My nickname is Alan. It's cool. Okay. First, I'm going to check your pulse. We may have already made you nervous. Is that okay?
That's fine.
Okay. 6, 7, 8, 9, 10, 11, 12, 13, 14. All right. So 90. All right. Do you mind writing down 90 so we don't forget? So that's, and how are you feeling right now?
Okay.
Okay. All right. So now I'm going to be really mean to this guy. And there's something called the Trier social stress test. I'm not going to do it in its entirety, but I'm sorry, this is meant to get you upset. Okay? So don't take it too personally. I feel bad doing this to a stranger. So I'm going to give you a task to do. Before I do that, let me actually set this up so that we can do this right away. Have any of you heard of the dive reflex? Anyone who was with me last year would know what we're doing here. I'm sorry? I've got towels for you as well. I'm sorry? Yeah, I would take the tie off. Okay, I'm sorry. So, all right, so what we're going to do is I'm going to quiz you in front of all of these people, and please don't be mad at me. I wish I knew this guy a little bit better. So I want you to start with the number 13,985 and subtract 7, and then continue subtracting 7 once you get your answer. 13,985 minus 7, go. You're taking too long. 13,985 minus 7, go.
78.
Made a mistake. 13,985.
71.
13,985 minus 7, go.
71. 74.
You're making too many mistakes. 13,985 minus 7. You get nervous yet? 13,985 minus 7, go.
Okay. 78. 71. 70. 64.
We need the 13,000. 13,985 minus 7, go.
I did it already. I'm going down.
Okay, perfect. All right, let's check your pulse. Sorry about that. This goes on for a long time, actually, generally. Let's see what we got here. 2, 3, 4, 5, 6, 7, 8, 9. Actually, his pulse didn't go up a whole lot. It's really just 96. So I didn't get a really big response from him. This generally goes on a lot longer. But how do you feel, at least? How did you feel during that process?
Yeah, you rushed a little bit.
I'll rush you. You feel...
Okay, no. Yes, no, that's fine.
Okay. So what I want you to do is hold your breath and dunk your head in here. And so you need to submerge your face in your neck, but don't submerge your ears, or we'll get a cold caloric and he'll puke, and then this video will go viral once we put it on the internet. Okay. So again, you don't have to submerge much. It just has to be this. So count to 10, dunk your head in there. You're going to get a rush. Count to 10, and then come on out.
How much you want me to be inside?
Just this area
Just
here.
like keep inside and out?
So, no. You need to keep your head in there for about 10 seconds.
10 seconds?
And just try and submerge your neck as well. Thank you. We're going to give this guy a huge applause and buy him dinner.
Yeah, you have.
Yes! This guy is all in!
I think the heart rate is up when you just volunteer.
Yes, very good. Here you go. This guy's awesome.
Do I win something?
All right. Now I just want you to take a few... what do you need?
Me. Well, that's the whole point.
Oh, pulse you. Yeah, thank you. This guy's better than I am. I need this guy in my
Do
life.
this for like uselessly at the end.
So it's 66. And it was much less bounding as well, much less sort of pressure in it. But the bigger question is, how do you feel right now?
Oh, much fresh.
Think about just your inner emotions, your level of anxiety. What would you say?
No, really, I'm feeling relaxed.
So I would encourage any of you to try this. I'll leave this out here when I'm done. I can tell you that you will notice a change in your emotions and moods from this. And this can be emulated much less dramatically with just a gallon ice bucket and a Ziploc bag. Patients, particularly patients who are wanting to inflict some level of pain, because there's that aspect of it too. I think it's a wonderful thing that you can use. So, all right. And I actually did like ham D's on myself as I went along.
You did this
I did every day, twice a day actually, in the morning and after work. I'm sorry? That's right. Absolutely. So it's like hardening, or they would go right from the saunas into the ice baths or whatever. I think there is benefit to this. And again, what we're doing is we're getting into the parasympathetic system. Is for people who aren't aware of that, you're eliciting the dive reflex, is what you're doing. Everybody give this guy a round of applause. Seriously, you are awesome. If I could do anything for you, certainly dinner. Anything else, you let me know. So all right, this is the last slide here, and I'm going to get a little philosophical here, since I've got you all in the room. So this is my uneducated hypothesis, okay? So almost everything has a neurobiological correlate, and we live and exist in our brain's neuronal firing, maybe. So again, I put a couple of caveats there. Anybody who comes up with a theorem and doesn't put in caveats is just begging to lose. Like, everybody ultimately gets disproved, so you might as well put the caveats in the first place, right? So what I'm getting at is that every emotion we feel, every thought we have, everything that we experience, every conversation, everything that exists in our world has a neurobiological correlate. And my guess is that's mainly transmitted at the level of neuronal firing and pathways. Again, I say maybe because it may be more complicated than that. You know, I lied to you when I said action potentials are all or none phenomenon. There's actually some level of phasic release of neurotransmitters. So there's some signal there even when it's not sort of fully firing. And so, you know, again, this is just a rough caveat. So now I'm going to make a couple of, actually we'll go to the board quickly. I'm sorry? We'll get there. All right. So I'm going to make a couple of analogies, and I want you to try and follow me on this. So I'm introducing these concepts gently because we are very much attuned, all right, to not think this way. But let's think about cough, okay? What are the three most common causes of cough? Postnasal drip, GERD, and asthma. All right, good job. I have to look this stuff up. All right, what is a medicine that treats cough? Methadone will treat cough. Opioids will treat cough, right? So methadone will treat a cough, right? So if we take everyone who has a cough and we put them in a study and we give them methadone, everybody's cough is going to get better. If that's what we're measuring, we can say, hey, methadone treats cough. But what we've really done is we've treated a symptom, okay? Let's say we gave everybody a PPI, a proton pump inhibitor, and a subportion of the people with GERD responded to it. We can say, hey, a PPI treats cough. But if you just keep looking for PPIs, you're only going to treat cough in a subsample of the population until you understand what is driving this phenomenon. Because these things have different symptoms, unless you understand what's actually going on, you're missing the boat. And now I'm going to give you a more real example, because that seems obvious. Duh, cough isn't GERD. But let me give you a real example. Let's talk about pneumonia. What are the different causes of something that can present as a pneumonia or a pneumonitis? Now, I don't need y'all to be super smart, but just general categories. So like a chemical, a pneumonitis type thing, right, which could turn into a different kind of what else can cause a pneumonia? Bacteria, right? Or so that would ultimately lead to some other, I don't think of obstruction necessarily, except through a secondary mechanism of creating a pneumonial type picture. But I'm sure that people with obstructions are much more set up to create, because it creates an environment which is more able to breed these things. So let's think about this here. If we look at pneumonia.
Antipsychotics?
Through what?
Antipsychotics?
Through a chemical pneumonitis, I'm guessing, or something?
Yeah.
Okay. So what I'm ultimately going to try and get at is that if we look at pneumonia as cough, fever, and signs on an x-ray, and we treat, if we don't know anything more about what's causing it, let's say we treat it with an antibiotic, right? We're going to catch some of these people. We treat it with an antibiotic, some of these people are going to get better. A lot of people are going to get better anyways because there's a natural time course to this. But until we can get to that next level, we're not going to be able to improve our outcomes in this. So that there is azithromycin. Okay? Azithromycin is a macrolide antibiotic. It binds to the S50 ribosomal subunit of bacteria. So what that does is it stops bacteria from creating proteins. If it can't create proteins, it can't reproduce, and it dies. So the underlying mechanism of a pneumonia is inflammation in our lungs. That's what's going on. We are creating inflammation. Our body is seeing something there it doesn't want and creating inflammation, which ultimately leads to symptoms. Okay, that's the final common pathway. You can give an anti-inflammatory like cortisol and your symptoms are going to go away for a little while, right? Azithromycin, interestingly, will bind to whatever it binds to. It doesn't know that it's an antibiotic. Any bacteria that it can be taken up to, anything in our bodies that it can be taken up to, it will do what it does. So certain things it will treat very, very well. Certain things it won't, right? So azithromycin is also an anti-inflammatory, which is why I picked it. So it can even treat pneumonitis and viral pneumonias through its anti-inflammatory pathways. And what I want to sort of make a correlate to is depression, right? We are treating all of these people with all of these different medicines. So let me not say depression. Let me say MDD. When we want to do a study for MDD, we say, who has MDD? What is MDD? It's these symptoms, right? We
take them all and we throw them in this trial and we always get the same results. 30% of people get better on their first try to remission. We never do better than that with our drugs. Think about the correlate here. There are different things driving this with different underlying physiologies. And until you get in there, you've lost the game. You're not going to have wildly successful drug trials of MDD until you redefine MDD. So what happens when we actually figure something out is amazing, right? Somebody is hypothyroid, horribly hypothyroid, right? Low T4. This causes depression. But wait a second, that's not MDD anymore. That's depression due to a GMC. And we treat it with thyroid and people get amazingly better. We have wonderful response rates. What I'm saying is that all of these are due to general medical conditions. We just don't know them yet. There's these underlying things driving this. And until we can have psychological conditions are neurobiological conditions. So yes, environment is part of it, but environment is part of this too. You can treat somebody's thyroid depression with CBT, just not fully, because there's something driving it underneath. There is a neurobiological correlate to these things. You are increasing your compensatory mechanisms through those ways. Yes, there's other ways to get into the system, but what I'm getting at is that we have failed already. We are not going to get further until we can look beneath it, until we can think functionally. This is not functionally. This is just, you've got a list and you pick it. This is not neurobiological. And so I'm critiquing DSM very, very hard. They would burn me at the stake if they were here. So I'm being very negative. That's not very helpful. I'm going to try and be positive when we get to function and talk about what really could depression be? How could we really find these things out and then find putative treatments for them? Because the other thing is, let's say this only happens in 4% of people, right? If we just take MDD as a group, what treats this group, maybe perfectly, maybe 100%, is going to be completely lost in this 96% signal. Even if 4% of the people get completely better, because of the natural time course, we will never be able to prove that this medicine works until we have a better understanding of underlying disease.
So what are your hypotheses for those ones?
We'll get there.
Cortisol,
There's no.
cytokine?
Cortisol is, again, you have to understand, it's functionally. So we have to understand how these things are working functionally on a neuronal circuit basis. Cortisol will only ever be part of the explanation. Cortisol is going to be part of some of these, but how is it getting in on the full spectrum, right? Epigenetics is involved, genetics is involved, ions are involved, connections are involved, learning is involved. And it's that web that is going to be these things.
Do you think there's something to the adrenal fatigue hippies then?
Again, I don't know enough about it to comment. What I'm saying is that no reductionistic scenario is going to be completely correct for all of these people. There is something to it, probably. What I would say is, listen to, here's another great example that I didn't give. I didn't show the video of me on here. After I gave my first lecture, Dr. Hobbs was like, I'm going to have to hose you down, right? Because I looked manic up here. I was blabbering on a mile a minute. I've been feeling down since I've been giving these lectures. I've been tired. I've been having difficulty eating, difficulty sleeping the night before.
You shouldn't give these lectures.
It's cortisol, right? I'm a healthy person. That's a joke, right? But think about it. I got into this system. Something happened. I didn't take any drugs, but this happened to me. And again, I compensated for it. My body probably has the homeostasis to allow me to swing in without swinging out too far. But what I'm getting at is that we all operate on these sort of mechanisms. Some of us, again, have more ability to adapt to it, whereas some of us have roadblocks that make it very hard. And if you've got it there, you express the disease state. So what I'm saying is, to have normal functioning, you require a lot of functional modules to be able to be healthy. You start breaking them, if you can't compensate, you start expressing illness, is I guess ultimately what I'm getting at. And the idea of MDD being a real thing is a joke. MDD goes with GAD, it goes with migraines, and the reason is that one of these things is going to be all your migraine or GAD people, one of these things, because this is real. They're not lying to you. And that's, again, getting back to the point where comorbidity is because we have bad disease models. The way we need to understand these diseases is on functional bases, and that will explain these comorbidities. And if I had more time, I'd get into that, how I'm just talking about psychiatric phenomenon, but this ties into all this stuff. You heard about diabetes. Diabetes, people have depression. People with depression have diabetes. It's because they're sharing these same functional modules. So again, I'm waxing on philosophical. I appreciate everybody's time here. And certainly, let's give another hand for Riyadh. This guy's awesome. Here, let's get you on camera. Yes, you rock, Riyadh. Cool. Do you guys have any questions?
So what do you think are the things that will go in those circles in the bottom?
We're going to get to we need a little bit more information before we get there. Again, it's not going to be as clear as those circles. What we're going to have is maps. Again, we'll get there when we get there. That's a little bit of a teaser. We need to learn a little bit more about learning and about a couple of other things, and then we'll start talking about disease expression.
So once we fill in all these circles, though, will we start losing people to the general medical crowd? Like,
Again,
lose these people
listen,
to the
we're doctors, right? So what I'm encouraging us to do is, and I hear people say that, and it's a joke to me. Like, when people ask, is it in the brain or is it in the mind? That was on the first slide. Maybe. But no, I think that we can treat these people because we're going to be the specialists to take care of that side of things. Yes?
I mean, I'd like us to treat more of these people, too.
Absolutely.
I mean, thyroid depression, but they wind up
So
living.
here's an interesting thing. You can treat depression, even people who do not have a low thyroid hormone, with thyroid supplementation.
Oh, yeah.
Because what you're likely doing is, again, once we start seeing these webs, I got into this in some of my other lectures, there are bottlenecks. And if you can feed through that bottleneck, anything is going to improve it, right? So even if, I use a car analogy a lot, right? I mean, if you're driving on a slippery road, you can either get therapy to become a better driver on a slippery road, better tires to become a better driver on a slippery road, or stop driving on a slippery road. And that's what we're going to end up seeing. And that's what's actually happening here. It's not... I'm trying to talk about rational pharmacy treatment, like you do with an antibiotic. You sample somebody's sputum, you test it against the antibiotics, and it's rational, individualized care. You know that if it responds to it, if you can get it to high enough concentrations, it's going to kill it, because you've done the N of 1 experiment. That's where we need to be going towards. We're a little bit more complicated than a single, bacteria, but this is what we need to move towards, or I will tell you. Dr. Shimo was my supervisor last year, and he was like, it's a sad day when our best medication, he was referring to Lexapro, which again, I'm not picking favorites, it's a good medicine, is generic. We have not come up with anything new. And we have. You're just not going to get it approved when you have this disease model. You can't do it. If you're recruiting MDD and it's a subpopulation, you can't do it. It's not going to happen. So until we change this model, we're going to be stuck. I feel strongly about
I
that.
want to see, for example, let's say the folate supplementation, the thing that they have for prescription strength.
So do you know what folate supplementation is getting at ultimately?
Yeah, it's you're bypassing that, I forgot the hormone, but you're bypassing the...
Folate generally is acting as a methyl donor. You're talking about Deplin. Oh, tryptophan.
No, is it serotonin? Well, yeah.
Deplin is a folate.
Okay,
What folate does in our body usually is it acts as a methyl donor. So methylfolate. And that's one of those cofactors like SAMe. SAMe acts as a methyl donor.
For them to make that, subsidize that test that checks to see if we need a folate in a depressed patient and start ordering that with like a TSH.
So what you need to do, again, you can do that. You could probably have that sent off to a lab to some extent. But what I'm trying to encourage you all to start thinking is not in a single number. That's not what this is about. This is about functional stuff. So yes, clearly there's going to be somebody who maybe sole problem is low folate. But what I'm saying is that these phenomenon are going to be multi-determined in most cases, homeostatic phenomenon, like I had said before, where it's 10% this, 30% this, and what you really need to see is what is this circuit that's having problems and find a way in. And it doesn't have to be any of the things that they have, it just needs to be rationally guided treatment.
That's my point. The rationale is, let's take a look at your...
What I'm saying is, I think that we are not going to get huge success from just drawing a single lab. We need, if you all need to leave, you can clearly leave. We need to start looking at multi-dimensional stuff. So we're looking at graphs of folate versus cortisol versus this graphed over time with an fMRI that's functional. And again, this, as modalities get introduced to us, there's more possibilities for querying these types of things. But that's where, again, it's coming back to the same things. We're not going to find single gene stuff anymore. The GWAS stuff, it's done. Stop doing them. You know, if you understood these phenomenon, you just stop doing them for psych stuff. Like, yes, there are going to be certain people and certain groups that are going to have a single gene that tie together, and you'll help that family, and that's wonderful. But what we really need to start looking at is functional stuff. GWAS, plus epigenetics, plus life events, plus actual things that are going on functionally in this person's circuitry. That's what we need to be querying. As we understand what's going on, I think that will become a real possibility. So that is what I think the future of psychiatry needs to go for us to really be able to improve care, to give individualized care. All right. Cool. Thanks, guys. And don't get frustrated.